Hello, I'm Adrian Finnegan. This is Counting the Cost on Al Jazeera, your weekly look at the world of business and economics. This week, the way we pay for healthcare. Millions of people in the US go without medical insurance. Many file for bankruptcy because they can't afford to pay their medical bills. What are the chances of rolling out universal healthcare in an unequal world? We'll take a look at Zimbabwe's healthcare system, which is on the brink of collapse. Plus, do tech companies have a solution to the way that everyone accesses healthcare? We'll talk to an investor and CEO of a diagnostic app. Now, just because you're the richest nation in the world and spend more than any other nation on healthcare doesn't mean the outcomes are better or that more people will access health services. More than 500,000 people turn to bankruptcy in the US because they can't pay their medical bills. And more than 27 million people are without medical insurance. In the poorest nations, the weakest don't have access to even rudimentary treatments. Yet, it's a goal of the United Nations to achieve universal health coverage for all by 2030. How? Well, take a look at this. The World Health Organization estimates that it would cost around $58 per person per year to achieve universal health care in all low and middle income countries. That comes to about $371 billion per year by 2030. Where does that money come from? Well, the World Health Organization believes some 85% of the total cost can be met by domestic resources. In the 32 poorest nations, a funding gap of around $54 billion would need to be filled through international aid. And what will that mean in terms of outcome? Well, some 97 million premature deaths would be averted. It would also avert 20 million deaths from non-communicable diseases like heart disease, diabetes, and cancer. Life expectancy would jump anywhere between 3.1 and 8.4 years. Well, as the world inches towards spending $10 trillion a year on healthcare by 2022, we have two reports for you. In a moment from Zimbabwe, Haru Matasa takes a look at a public healthcare service that's on the brink of collapse. But first, from the United States, Al Jazeera's Shihab Ratanzi reports on how the health insurance industry is failing patients.
When Verdell Clark was diagnosed with cancer, she felt confident that her health insurance would cover her medical expenses. How many years, though, had you guys been paying in, though, to that insurance plan, though?
Oh, my God, ever since, 30 years, I guess, maybe.
But she wasn't fully covered. Her health insurance paid for most of her treatment, but there remained a few $1,000s that she was expected to cover and that she just didn't have. Her hospital withheld her cancer treatment. What about the Hippocratic Oath? First, do no harm. I mean, aren't they supposed to...
Well, I don't think that applied at that time.
And then she wound up detained at a courthouse after the hospital sued her.
I'm walking up there with shackles and handcuffs. I didn't bring any of my pain medicine because I didn't think I was going to be there all day.
This sort of trauma from medical bills isn't an uncommon experience for Americans. In fact, 2/3 of bankruptcies are due to medical issues in the US. To find out why, we traveled to Philadelphia to speak to Wendell Potter. He was once an executive at the health insurance company Cigna. Most people in the US pay monthly premiums to health insurance companies like Cigna as a safety net in case they need medical treatment of some kind, just as Verdell Clark had. These companies then determine whether they will receive and can afford that treatment. In 2009, Potter blew the whistle on the health insurance industry to the US Congress.
My name is Wendell Potter, and for 20 years I worked as a senior executive at health insurance companies. And I saw how they confuse their customers and dump the sick, so they can satisfy their Wall Street investors.
That year, the Affordable Health Care Act, or Obamacare, was passed. It did widen coverage and close loopholes insurance companies were using to refuse their clients' health care.
We are done.
And 20 million more Americans were able to get health insurance as a result, though still some 28 million Americans would remain uninsured.
Can you hear me?
But health insurance is still a for-profit enterprise. Yes, you can now get insured, but if you actually need treatment, it will cost you.
Just as bad, if not worse, is the rising number of people who are underinsured. These are people who are paying good money every month for their health insurance premiums, but finding that they now have very high deductibles. In other words, they have to pay a lot of money out of their own pockets before their coverage kicks in.
For Potter, the fundamental principles that guide insurance companies haven't changed.
To make as much money as they can, to bring as much revenue in, but to pay out as little as possible in claims. Because when that happens, they've got more money to reward shareholders and to enrich their executives. I know that because I was one of them that made quite a lot of money.
The statistics aren't in dispute. The US has the most expensive healthcare system in the world. However, when health system performance is compared, such as quality, efficiency, access to care, equity, and the ability to lead a long life, the US is last against other developed countries. The US does rank top for one indicator, though, the amount it spends on administrative costs per capita. And part of that money is dedicated to insurance companies hiring doctors and nurses as what are called medical directors. But they don't treat patients. They try to find ways not to treat patients.
Everyone who's employed by an insurance company knows that they have their part to play in making sure that that company meets Wall Street's financial expectations. So it doesn't have to be direct, that you will deny X number of things or treatments, but you know that if you're going to keep your job and hopefully get a raise and a bonus, you got to do what the company expects you to do.
Health insurance is expected to be a major issue in the 2020 election, but Potter recognizes the framing of the debate as one he and other executives would shape in the boardroom before funneling money to politicians.
The terms that are being used today are the same terms that I used to use, and in fact, in some cases, helped create. It is to get people to be afraid of change. There's a term that's an acronym that's used for this kind of propaganda campaign. It's FUD, and it's fear, uncertainty, and doubt. And these campaigns are designed to get people to fear change, to make them feel uncertain about what's being proposed and that they would benefit from it, and to doubt those who are advocating it.
My story be able to help someone there, because I know there's someone out there who's been through the same thing or even worse than I have. And so that I feel like my story may make a difference for someone, or it may embolden someone where they may speak out.
But for now, it's unsettling how familiar Verdell Clark's story is in the US and how powerful the forces are that want to keep it so.
Martha Tolana worries finding drugs for chronic illnesses is going to get a lot harder for poor and struggling Zimbabweans. Some public health centers have no drugs for HIV patients. The cost of 1 month's supply at a private pharmacy is roughly $60. A civil servant earns about $70 a month.
If you are going to buy ARVs, you are caught between a rock and a hard place, because you know you need the ARVs for you to maintain your life. But then if you buy the ARVs, that means you don't have food, you can't look after your children, you can't look after, all the people that depend on you.
Those who can afford it go abroad for their treatment. Others use the well-stocked, expensive private facilities, a luxury millions of others don't have. Zimbabwe has more than 20 registered health insurers who have about 800,000 members. The government has its own health insurance for civil servants, which caters roughly to 340,000 workers. That means most people here don't have medical coverage. While children under the age of 5 receive basic free treatment at public hospitals, everyone else without health insurance pays cash.
For effective pain management, the patient must have regular, uninterrupted access to medication. That medication has become extremely expensive. Traditionally and historically, that medication has been funded largely by donors. But we're finding that donors themselves, not through lack of will, but because of pressures on them, mostly local donors, they're unable to support that.
Doctors have been striking for nearly 2 months over poor pay and work conditions. It's another sign the public health sector is in trouble. After numerous negotiations broke down, the government issued this ultimatum.
Doctors who are not coming to work will be disciplined. So the first thing, whoever is not coming to work, they will not be paid.
Some here blame the collapse of Zimbabwe's public health care system on corruption and the state's failure to prioritize. Government officials say Western-imposed sanctions are the reason for the crisis, not them. But it's patients who end up suffering, and as Zimbabwe's economy worsens, there is no sign their situation will improve soon. Haru Matasa, Harare, for Counting the Cost.
Joining us now from Oxford is Andrew Farlow. He's a senior research fellow at Oxford Martin School. Andrew, good to have you with us on Counting the Cost. As we were hearing there are many issues with the US health industry, pharmaceuticals, for-profit hospitals, insurance, vast administration, insurance not even covering the cost. I mean, is this a free market failure or a failure of capitalism?
Well, I'm not sure I'd go, good morning, Adrian, I'm not sure I'd go as far as that, but the US does rate in terms of its performance on hospital performance and health performance and its spending on health much lower than it would be justified by the amount it actually spends on health. It spends about 17% of its GDP on health, which is about 1 in 6 dollars, and yet it ranks, I think, 42nd among 224 nations. And if you look at the most developed industrialized countries, the top 35, it's 22 in the table, which tells you something that about the way in which that system works. And it's a very high cost system, but it's also a system that misses a lot of people. You probably know well about the way in which the insurance industry works and the way in which 20 or 30 million people quite regularly are not covered by that system. And that's a big source of its actual relative failure relative to other countries. And then when the expenditure takes place, when the hospitalisation takes place, it is quite bureaucratic and there's quite a lot of paperwork. And there are things within the system that don't necessarily push in the direction of efficiency.
Is there anything to recommend about the US system of healthcare? Is there anything that anyone else should be looking to replicate?
That's a really interesting point. I mean, where it's done the best in the US is actually the best of the best globally. If you need the top quality treatment of some sort or other, it can often be found in the US. But one of the things to take out of this story is actually that for relatively lower levels of money, you can actually achieve pretty high success. So one of the problems with sort of highlighting the huge amounts of expenditure in the US is it kind of can send the signal that you need to spend lots and lots. And as you know, there's big pushes to create universal healthcare coverage, basic package, and actually you can achieve a lot with a lot less than in the US.
The World Health Organization says that $371 billion, or $58 a person per year, is all it'll cost to get healthcare to low and middle income countries. What kind of care does that provide, and is that even feasible? Is anyone willing to pick up the cost?
Well, there's two things. The first thing is to get this whole thing in perspective. You quoted a number. Well, we're in a global economy of $80+ trillion a year. So when we talk of 300 or 400 billion, it sounds like a lot, but it's actually only a fraction of one of those billion, one of those trillion numbers. So it's actually as a percent of the global GDP, it's a fraction of a percent. The second thing is that the push to create universal healthcare coverage and the numbers you've talked about per capita, that's for a very sort of basic package. And one of the things that's been going on in the last 5 or 10 years has been measures to try and actually make it that many countries can afford that package. One of the things that perhaps 10 years or so ago that we realised that was important to get right is that there's a lot of tax revenues out there. There's a lot of economic activity going on that's not paying its fair whack. So one of the things that the WHO and the World Bank and others have been analysing and trying to understand is the sources of this revenue. We have actually trillions of dollars of resources that don't find its way into the mechanisms that could actually pay for that. We know that in the very poorest countries of all, there will need to be a period of time where richer countries contribute. And the numbers they sound a lot, but they're quite small. If you think of, I studied financial crisis, if you think of the number you've just quoted relative to the cost of the bailout 10 years ago, it's fairly trivial. The other thing about the numbers you've just quoted is that in terms of health impact on the poorest, one of the terrible things about it is it's often the most vulnerable. It's the people who can't get access to cash when they need it. And one of the sort of killers, as it were, is that when you need health expenditure, when you're in a very poor country and something's gone wrong in your family, you're held back from getting good health treatment because you can't quickly or readily get hold of the cash. So a large chunk of the initiative to create these programs for universal healthcare coverage is to make it that people in advance, in many cases, contribute. So there are schemes in which even very poor people put something every now and again, and that gives them some sort of automatic right to some sort of access. So it's not just rich people paying money in, it's richer countries paying towards the very poorest for a period of time.
Andrew, it's really good to talk to you on Counting the Cost. Many thanks indeed for being with us.
Thank you, my pleasure.
Well, with the trillions spent on healthcare, it should come as no surprise that investors are trying to crack the industry with new tech-related products. The global digital healthcare market is expected to hit $504 billion by 2025, according to Global Market Insights. And the health tech wearable market, which includes your smartwatch, trackers, could be worth $60 billion by 2023, Juniper Research estimates. All right, so let's talk health tech with George Davis, who's the director at Hambro Parks. George, good to have you with us on Counting the Cost. Why is the healthcare industry the least receptive of industries to technological developments?
Well, I wouldn't say it's the least receptive. I just think that it does face some challenges. Global healthcare is a huge part of global GDP, but of course, a great deal of it is provided by governments and legacy systems. So change and innovation does take time. That being said, I think we're seeing a huge proliferation of startup businesses and innovative business models in the space. And I definitely think that over the long term, we'll see absolute transformation, particularly as you see large businesses like Google and Apple entering the space, as well as new startups and more established players who are now spending more and more time thinking about changes to the system. So I'd say over the long term, we're going to see dramatic shifts. At this point, perhaps healthcare's lagged somewhat, but I don't think that will be the case over the long term.
I've used a company called Thriver for blood analysis. I did the test at home, sent it off, fantastic, got all the results. But I suppose the biggest challenge for companies like them, is data. How do you store it? What do you do with it? And the potential for misuse.
Yeah, I'm familiar with Thriver. It's a really interesting business, a great British innovative startup, actually. Data storage is obviously one of the challenges that health tech startups face, both because of regulatory issues, but also because of the expectations of consumers who are increasingly, I think, aware of the challenges around the data that they give away, both consciously and unconsciously to big businesses. I do think this is a challenge for earlier stage healthcare businesses because there's a lot of cost involved and there's a lot of trust involved. And in the minds of consumers, I think that often comes from more established players from the role of government. That being said, I do think those challenges are definitely possible to overcome for startups. As long as they obey the rules and use the services that are available to them, I think they can absolutely resolve it. And what I would say on the other side of the equation is that the power of big data in healthcare to really change the way we diagnose and treat illnesses and also long-term conditions is one that a lot of businesses are definitely looking to harness, Thriver being a good example. And so I think we need to be conscious as consumers that there is a trade-off, but we need providers of services to be very clear with us what they're going to do with our data, what data they're storing and how, and build that trust over time to capture that opportunity.
One of your products is Smart TMS, a mental health treatment for depression, helping patients with severe mental health illnesses. Now that, from a medical point of view, is an area that requires a lot of skill in terms of managing patients. How does it work?
Well, so Smart TMS is a non-invasive treatment for mental illnesses and challenges that people face, and that's obviously a massively growing sector. Importantly, it is not a chemical solution to the challenges that people face. So, and we wouldn't say that there is, as an investor, we wouldn't say that there is one solution to those challenges at all. And it's absolutely a challenge that at the consumer level, people will have different things that work for them. This effectively uses magnetic stimulation to change patterns in brain behavior and can address a number of challenges, depression, anxiety, anorexia, a whole bunch of issues that people face. And I think as we move into a phase where people are more accepting and open about the mental health challenges that people face. And that is absolutely a good thing, I believe, and something that will increase overall social well-being in societies. I think you need a suite of these opportunities. This business that we've invested in is growing very rapidly in the UK and is a really powerful innovation, but it won't be the only one, and you need to take a case-by-case basis as to what the right one for specific users is.
Now, with a shortage of 7 million doctors worldwide, Ada Health hopes that it can fill a gap that would reach parts of the world where healthcare is something of a lottery. Right now, headquartered in Berlin, it's developing and trialling its app. Al Jazeera's economics editor, Abid Ali, spoke with Ada's CEO, Daniel Nathrath, and asked how Ada was different to people Googling their symptoms.
You're completely right. 8 out of 10 people Google themselves, for example, in Germany, where I'm from. The thing with Google is it's a great tool for generalized information search, but the results are not personalized to the user and they're not actionable because Google doesn't know enough at that point in time about the user. Ada works, in contrast to that, very much like a WhatsApp chat with a trusted family doctor that you have access to 24/7, except that in this case, the family doctor is not a human, but it's an artificial intelligence that supports you in finding out what's wrong with you and what you should be doing next.
And where have you deployed the software, and are you working with health professionals or services?
Yeah, so Ada has been launched basically in all countries in the world where there is an app store or a Google Play Store, which means over 150 countries. And it has become the #1 app in the medical category in the App Store in 140 countries. And we do have partners that we work with, for instance, with a large health system in the US called Sutter Health on the West Coast. We also work with some of the largest health insurers in Germany. And there are medical professionals and some of the leading medical institutions in Europe who are using our doctor-facing software.
And what is the reaction of those health professionals?
Actually, the reaction of health professionals to Ada is very positive. I was expecting at least some of them to be a little bit skeptical and was wondering whether some of them would say, you know, is this kind of a threat to my job? But that's not the case at all. The real health professionals, once they realize that Ada is actually very accurate, they really appreciate the support it gives them in getting to the right diagnosis faster.
What's the backbone of the technology? I mean, how do you get the AI to read through medical textbooks, or what do you do?
Ada has been around since 2011, and the first 5-6 years, we didn't even go to market. We had a large team of 100+ doctors and computer scientists working on building a very, very extensive medical knowledge base and refining a reasoning engine behind it. And then we only launched the app for patients about 2.5 years ago. And what we're doing now is that we're using certain machine learning techniques also to learn from all the cases that come into the system. We're trying to create feedback loops to make the system better and better every day.
Now, we usually talk about Silicon Valley trying to disrupt certain industries. Why is it taking such a long time to disrupt the healthcare industry?
I think it's understandable that in healthcare, things take longer. If you look at some e-commerce businesses, let's take a food delivery business, for instance. There you can create a simple shop solution, a minimum viable product, as they say, and then you start generating revenue, you react to users, and you iterate. And if something goes wrong, it's actually not that big a deal. For instance, if you deliver the wrong pizza, it's annoying for the customer in that moment, but it's not life-threatening. In healthcare, you have to be a lot more careful. This is why there is medical device regulation. With a software like ours, we have extremely high standards in terms of accuracy, data protection, data privacy, because this is some of the most sensitive data that exists. And if you use a product like ours, you'll be glad when you have a heart attack and it does give you the right information. It does not tell you, oh, you just have a shoulder sprain, don't worry about it.
Is this something that needs regulatory approval?
Yes, so Ada is certified as a medical device, and there are obviously different regulatory authorities in the EU, in the US, and in Asia and in other countries. And we're working very closely with the authorities to make sure that we obtain all the right certifications. In Europe, we're classified as a medical device.
Daniel Natharath, thank you very much for your time. Really appreciate your time today. Thank you.
Thank you very much.
And that's our show for this week. If you'd like to comment on anything that you've seen, you can tweet me. I'm at @afinnegan on Twitter. Please use the hashtag AJCTC when you do. Or you can drop us a line. countingthecost@aljazeera.net is our email address. As always, there's plenty more for you online at aljazeera.com/CTC. That takes you straight to our page. And there you'll find individual reports, links, even entire episodes for you to catch up on. But that's it for this edition of Counting the Cost. I'm Adrian Finnegan from the whole team here in Doha. Thanks for being with us. The news on Al Jazeera is next.